diagnosis of a lady just this week, as a matter of fact. She didn't walk in saying she had lupus. She walked in saying that she was confused. She was confused. And we went from confusion. By the way, why is your creatinine 4? By the way, why do you have low platelets and anemia? Oh, gee, yeah, got brain and kidney and blood and wow. And then it turns out she also had a positive ANA too. So give you a chance to look at this. There are 4 skin manifestations. There are four skin manifestations, okay? The malar rash, which is classic, photosensitivity and oral ulcers, discoid lupus, that's what Seal has. Seal has that. Can still marry Heidi Klum and have lupus apparently. Okay, now the other thing is joint pains is often the chief complaint in most people. Now also on the blood, whether you have leukopenia or platelet problem or blood count problems with hemolysis, any one of them counts as one criteria. In other words, if you have leukopenia and thrombocytopenia and hemolysis, that's not 3 separate points. That's not 3 separate points. That's 1 point for blood. Now the renal manifestations varies for everything from asymptomatic sclerosis to proteinuria to hematuria, red cell cancer, outright being on dialysis. But no matter what manifestation you have, it only counts as 1. And when a young person has a stroke, a 34-year-old person, a 40-year-old person has a stroke, why are they having stroke could be vasculitis from lupus. Vasculitis from lupus. The serositis, remember the pericardium, the pleura, the pericardium, and the around the lungs, the serosa, they all count as one manifestation. And the serology, remember, the ANA is sensitive but not specific. What do you do about double-stranded DNA? Well, if it's positive, you're golden, you have lupus. Now, what do you have if you have a positive ANA but a negative double-stranded DNA? Well, the ANA is not specific. The double-stranded DNA is negative. You don't know if you have lupus. And the answer is anti-SM. Anti-SM. That's where SM comes in. Smith. In other words, the portion is positive for ANA, negative for double-stranded DNA. How do I know if I have lupus? SM. So rash, joint pain, fatigue, most likely to be lupus. There's the malar rash. And diagnostic testing, the best initial test is ANA, most specific test, not just the double-stranded DNA, but anti-SM. It's particularly useful in the 40% that have a negative double-stranded DNA. Now, which of the following can be used to determine the severity of a flare? Or a person comes in and they're confused. Man, are they having encephalitis or are they having lupus flare? Well, you have another person who's got joint pain. They have joint pain for some other reason or a lupus flare. They got some hematuria. They're having a kidney disease for some other reason. They're having a lupus flare. And the answer is complements drop, double-stranded pop. The complements drop and the double-stranded pop. And that's how you tell it's a lupus flare, because complements drop, you feel sick. Of course you feel sick, you're not getting enough complements. Now, a pregnant woman with lupus has a negative anticardiolipid antibody. Anticardiolipid antibodies is one of 2 phospholipid syndromes. One of 2 phospholipid syndromes, because if she had that, you might end up using aspirin and heparin to prevent spontaneous abortion, certainly to prevent a recurrence, Now, what do you do for Rho? Rho, what's the baby at risk for? Rho tells you that this baby needs to get a baby EKG. You need to get a baby EKG, because Rho or SSA tells you that you're going to have little baby heart block and get a little baby EKG, maybe need a little baby pacemaker. Row your baby gently down the block. So that's how you know. Row baby. Okay, now, on the CCS, computerized clinical case simulations, complement, Smith, and double-stranded DNA should be done on all of the patients that you think that have lupus. Remember, the most common anemia is not hemolysis. The most common anemia is the anemia of chronic disease. The most common anemia is not hemolysis, the anemia of chronic disease. The most common anemia. Now, lupus has, they're tired, oh so tired, and hair loss. These are not part of the 11 ARA criteria for lupus, but it's certainly part of it. Antiphospholipid syndrome is an important question that goes along with that. Which of the following hypercoagulable states is most likely to recur? Which is most likely to recur at a high SID rate? Now, treatment, lupus flares, glucocorticoids, steroids, that hasn't changed in 60 years. And joint pains, non-steroidals, hasn't changed. Now, hydroxychloroquine, which is an anti-malarial, hydroxychloroquine has been the same. Remember, retina problem with hydroxychloroquine. Now, the first new drug for lupus, and it's not even the greatest drug, has been approved in the last 40, 50 years, and that is a drug that is called, if you continue to relapse on stopping your steroids or it's progressing, we have a drug called belimumab, which is basically a condom for your B cells. It inhibits B cell activating factors. You know that? There's a B cell activating factor? I didn't know that. Well, I do because I'm me. But the thing is that what do? Inhibit those B cells with belimumab. Belimumab. Get rid of those B's with the belimumab. Well, they didn't call it nutrilimumab. And also, here's a really good question. The whole point of why do you have to biopsy everybody who's got lupus nephritis? Why am I biopsying you? Why am I going to hurt your kidney? I don't want to hurt my kidney. No. Why biopsy it? Because you want a piece of me? You want a piece of me? Okay, take a piece of me. Well, why do you have to take a piece of me? Because you don't know whether the person needs cyclophosphamide. Why do you have to take a piece of me? Because maybe I can save you from dialysis if I give you 2 drugs. Steroids and mycophenolate. Steroids and cyclophosphamide. Maybe you have sclerosis and I can't do anything about it. So why damage your bladder with cyclophosphamide? Hemorrhagic cystitis, cyclophosphamide, hemorrhagic cystitis. Mesna prevents, Mesna prevents. But I got to biopsy you to be sure. You don't want to expose people to cyclophosphamide unless they absolutely need it. What is absolutely needed? Advanced stage disease, proliferative. Proliferative disease, cyclophosphamide mycophenolate. Proliferative disease, cyclophosphamide mycophenolate, excuse me. Cyclophosphamide mycophenolate with proliferative advanced disease. Oh, you just got scarred up kidneys? Don't give either of them. Maybe just not even give steroids. Now, drug-induced lupus. Here's an excellent question. What's different? Much more often in men. You're against those men. You're against his stones. Not her stones, but his stones. Briticism for testicles. Okay? Hydralazine does it, procainamide, isoniazid it. Well, the interesting thing is I saw a patient this week that had regular lupus that had the bad luck to have been put on hydralazine for another reason. It wasn't the hydralazine because she came in with confusion and renal. That's the question for you. You see, drug-induced lupus gives antihistones and it spares the kidney and brain. Drug-induced lupus spares the kidney and brain. Conrad Fisher has a patient admitted with kidney and brain dysfunction. She has recently been put on hydralazine. She's got an ANA and a double-stranded DNA that's positive. True. What's the most likely cause? Native SLA. Native SLA. Why not hydralazine? Because even though the person was on hydralazine, they had brain and kidney and double-stranded DNA, and it's highly unlikely to have that too. Double-stranded DNA is with native lupus. Histones is with drug-induced lupus. Thanks so much for coming to join me, and I hope we get feedback from you, and we're glad that you are taking the time to learn from this special modality. Good luck on your test. See you in the next section.